Thank you very much for inviting me. And I was asked to talk about childhood trauma and stigma in people with HIV, so I will do that. I am neither an expert in HIV nor stigma, so you might wonder why the heck they invited me, and I'll do my best to justify my presence. A couple of words about conflicts. I do receive royalties from the sale of the book that I'm going to be mentioning. My research is supported by CIHR, and my work and myself, I'm supported by the chair that is funded by the hospital and the university. So I'm going to talk about childhood adversity and its relationship to physical health and mental health over the lifespan in general. And then I'll focus in on how that relates specifically to HIV. And then bring stigma into that perspective. And then if I can manage my time effectively, I will read you a little story that is pertinent to that from the book Damage. And then I want to talk about what we need to do at a societal level, at an organizational level, and individually as healthcare practitioners in order to try and shift some of the culture around this. So this triangle pretty much describes my academic career. It's all been looking at various aspects of how psychological trauma of different kinds is related to disease and illness, and in particular on how so much of what we do in medicine, whether we recognize it or not, has a foundation in relationships. And where I'm most comfortable is talking about childhood adversity in particular and childhood trauma and how that relates to attachment relationships and insecurity in close relationships and the impact that those have on adult disease and illness. And today I'm going to push at the boundaries of my comfort level and talk more specifically about stigma and HIV. So starting with childhood adversity and abuse. So a lot of you will be familiar with Vincent Folletti's work, which is where the kind of modern story of the relationship between childhood adversity and adult illness started. This is now 2 decades old plus. So at the in an HMO in San Diego, they looked retrospectively at childhood adversity that their adult patients were reporting and just looked correlationally at how that was linked to various health outcomes. And if you know that work, you'll know that they used what an adverse childhood experience measurement instrument, which has now come to be known as the ACE questionnaire, which was intended just to be a research tool. It was never meant to be a shorthand description of people's experience, which is how more and more it's been used these days, in which they defined 10 categories of adverse experiences that children may have, got people to endorse whether or not those were true for them. And through that, they could give everybody a score between 0 and 10 for the kind of cumulative not so much amount, but types of adversity that they had experienced. They didn't get the categories exactly right, but it was a very useful tool. And what they were able to demonstrate was a couple of things. One of them was that experience to potentially substantial adversity in childhood is very common, so common that it's the norm. So a score of 0 actually occurs to the minority of people. It was only 40% of people who scored a 0. And that there's a gradient of decreasing prevalence with increasing scores. There's been a lot of work that's done since then that's looked at what kind of a more comprehensive and better measure of ACEs would be, which would include things like being bullied, being treated badly because of your racial identity or other aspects of identity, being in foster care, growing up in an unsafe neighborhood, things like that, that were not included in the original scale. But the original scale was helpful to demonstrate just how common these experiences are and their potential impact. This is data from Tracy Afifi. So this is Canadian data from a representational sample with really robust definitions of what counts as childhood physical abuse, childhood sexual abuse, and exposure to intimate partner violence, which is virtually always exposure to violence against the child's mother. To demonstrate that at that level of severity, child abuse is extraordinarily common. It's 1 in 3 kids. Right? So, which means that it's 1 in 3 of the adults that we're walking past on the sidewalk, on the street, or treating as patients who've had significant abuse. So now we're talking at narrower categories, kind of more severe exposures, and we're still talking about 1 in 3. So the relationship of that to adult physical illness, the first time you see these numbers, I think is really quite stunning. And that's that there tends to be a gradient. The more exposure, the greater the adult risk, or at least the correlation becomes higher. So that, and here this is looking at COPD. So compared to no exposure, you can see how that gradient rises with increasing exposure until you get up to scores of 4 or more, where the odds ratio is almost 4. It's not too hard to kind of imagine that the mechanism there might be smoking, right? That people with that kind of early adversity are perhaps regulating their mood or more susceptible to peer influences or something, or smoking more and end up with COPD. This is what the gradient looks like for stroke. It's not nearly so stepwise, but you can see at the higher levels how the odds ratios are higher. And so there's been a ton of work on this since, and the diseases that are linked to ACEs and abuse now are essentially a list of most or all of the chronic diseases that use up most of the healthcare budget and are kind of most common chronic inflammatory and infectious illnesses and some cancers. Enough that a couple of years ago, the American Heart Association put out a scientific statement to review that evidence and conclude that there's substantial evidence that links childhood adversity to cardiometabolic disease with an effect size that's similar to smoking. The relationship to mental health outcomes is maybe more obvious and stronger. So this is, again, work from Tracy Afifi's group. She's from Winnipeg, to show that the risk of many mental health outcomes is at least doubled among people who've experienced that 1 in 3 who've experienced abuse and witnessed intimate partner violence in their kids. And this is just a cherry-picked statistic from one study that I just reproduced because it's so stunning that they found that men with an ACE score of 6 or more had a 46-fold increase in the likelihood of becoming injection drug users. And when you look at what disorders have been linked to ACEs and child abuse, it's virtually the entire DSM. The links to functional disorders are stronger than the links to chronic organic illnesses. And this is a meta-analysis that was looking at a number of functional syndromes. And I don't know if you can see, but the kind of composite odds ratios are in the range of 2-ish. So there's now enough longitudinal research and mechanistic research that I feel confident in understanding childhood adversity, not just as a correlate of adult illness, but in fact as a causal factor. And we understand it as a cause of causes. so that childhood adversity is linked to a number of health risk behaviors. I was pointing out smoking when I was talking about COPD, but another number of other behaviors that also increase health risk. It's associated with physiological changes, linked to many of the social determinants of health. It has interpersonal effects that I emphasize because we pay less attention to them. I think it leads to mistrust and difficulty in relationships, and particularly difficulty in the relationships that people count on to diagnose and treat illness. So that the patients who we find most difficult have reasons for their difficulty, right? And that interferes with health outcomes, as well as the individual psychological effects. So we understand childhood adversity as being linked to this whole cascade of causal factors that then play out in various physical illnesses and mental illnesses and the interactions that people have with the healthcare system. Not surprisingly, if you're convinced by that longitudinal impact spread over so many different diseases, ACEs are linked to early mortality, and in fact, the effects are large. So people with 6 or more ACEs die nearly 20 years earlier on average than those without ACEs, and another study commented on the radically different life course trajectories that are associated with exposure to ACEs. So how does that link to HIV? HIV is not exceptional compared to the patterns that I've shown you, except that the relationships are amplified. So evidence about childhood physical or sexual abuse, for example, among people who are HIV positive, suggests that about half have a history of childhood physical or sexual abuse. So that's, I mean, it's bad in the general population, 1 in 3, and it's bumped up to 1.5 or twice as high among people who are HIV positive. Childhood trauma is disproportionately high in ethnic minorities, particularly Indigenous people who have, in men who have sex with men, and in drug users. And I leave women to the end because I want to need to specify a little bit that childhood abuse is gendered. So women, it's 1 in 3 pretty much across the board, but girls are more likely to be exposed to sexual abuse, and boys more likely to be exposed to physical abuse, relatively speaking. And so HIV infection and trauma are one of those syndemics. So this is some data that I found striking. This is the same kind of gradients, but in this case, they're not looking at disease outcomes, they're looking at behavior. This is looking at the people's score on that ACE questionnaire as it relates to the odds that they've endorsed any one of these things happening in the last year: using intravenous drugs, being treated for an STD, giving or receiving money in exchange for sex, or having anal sex without a condom. And those gradients are straight and steep, and ending in odds of 4 times as high for people with 4 or more ACEs. This is data. The next couple of slides are data from a longitudinal survey that's being done in the Ontario HIV Treatment Network. This is showing the number of childhood adversities as they relate to people not being currently on antiretroviral treatment. So, and the reasons for that, you have to speculate. You can't get that out of this data, but presumably that's related to access. And this is a similar graph showing the relationship with current viral load, and that is less. There's essentially no gradient in the lower levels of childhood adversities, but at the higher levels, it's a significant difference. And this just to illustrate that various measures of socioeconomic status and and childhood adversity exposure are pretty strongly linked in this cohort of HIV positive people in the Ontario study. So I've drawn here trauma and HIV and stigma in a highly overlapping Venn diagram. You could also draw them in one of those triangles where all of the arrows are double-headed, right? So there's this kind of bidirectional causal relationship of a web of different factors. So I refer to the HIV stigma framework that I've been taught, which distinguishes between enacted stigma, internalized stigma, and anticipated stigma, which I find a helpful framework as a non-expert in stigma to think about the different aspects of stigma, particularly when trying to understand how this impacts on people and what we need to be doing about it. And this is a model that I found when I was reading in anticipation of this talk, reading up on stigma and trauma in HIV. No, I'm not going to lead through the model, just to say that when you start looking at the relationships between these various aspects of stigma and those various aspects of experience, what you find are complicated webs of associations, right? And and I would tend to think that most of these unidirectional arrows are in fact bidirectional arrows, right? It's everything is affecting everything else. So stigma clearly has important effects. It's related to higher viral loads, worse mental health, poor quality of life, increased substance use, poor treatment adherence, and reduced access to healthcare services. And as has been pointed out more clearly and in more detail than I will speak to, stigma is related to sort of every aspect of these people's lives, right? So there's the stigma related to being HIV positive. There's the stigma related to various aspects of identity and demographics that are associated with that. There is stigma associated with childhood trauma, and there's stigma associated with adult trauma, which is one of the consequences of childhood trauma. That the risk of adult trauma is substantially increased among people who've had that kind of childhood adversity. So I managed to do that quickly enough that I do have time to read you a little story. So this is actually not of a man with HIV. This is about a man with Crohn's disease who I've been treating for 20 years. And our treatment relationship and his experiences with illness, and especially with medical treatment, are kind of the core of this book that we've written in order to start a revolution, is how we phrased it, in terms of what needs to change in medical care. And I thought that the story that I want to tell you about is the very first time we met, because it illustrates some of the impact of stigma and some of the nuances, I think, of how that affects people. So his name is Isaac, and this passage is from a chapter called Fucking Dead Weight, which is how his father used to refer to him. So when Isaac first came to see me, I thought it was to get help coping with Crohn's disease. Psychiatrists at my hospital who treat people with physical illnesses had divided up the diseases between us, and Crohn's disease belonged to me. Crohn's causes the gut to become swollen, painful, and dysfunctional, sometimes for long periods, often unpredictably. It means days with dozens of crampy, bloody, urgent bowel movements, nights lying awake with fever, sweat-soaked bed sheets, and pain. It comes and goes, often with no pattern. It is an invisible disease and elicits very little sympathy. Isaac told me that parts of his intestine had been removed by a surgeon 5 times, each a few years apart. Usually people with Crohn's disease take powerful anti-inflammatory drugs to control the disease. Some need surgery, but drugs are the mainstay. Isaac, on the other hand, wasn't taking any medication when he came to see me. He hadn't found it helpful. Instead, Isaac told me that he was prepared to manage his disease with repeated operations. I've done the math, he explained. Each time they operate, they take out 8 or 10 inches of intestine. The operations have been 5 to 7 years apart. My small intestine is 20 feet long. I'm 45. I have more intestine than I have years. Why take the drugs? The arithmetic was right, but I'd never heard anyone speak of repeated major operations with such cold-blooded calculation. Isaac showed no hint of anxiety. He seemed to have a version of Crohn's disease that was resistant to the usual drugs, but it wasn't making him anxious, and as far as I could tell, he wasn't depressed either. So why did he need a psychiatrist? From the start, I saw Isaac's strength before he let me see anything else, and his strength was impressive. It wasn't just the surgery calculation, although that would have been enough to capture my attention. He was articulate, intelligent, a bit intimidating. He held a senior position in a large labor union. We spoke only briefly about his work, but he conveyed his passion for it, and I had the sense that he would be a tough opponent in a dispute. His appearance reinforced the impression. He was skinny, but he didn't look weak. He wore a white dress shirt, a vest, a woolen tie, a pair of jeans that looked new, and well-worn cowboy boots. His gray hair was long and a bit unkempt. He had his own style. Isaac looked around my office. At a first meeting, people often look around nervously, but he didn't look nervous. It was more like he was taking his measure of me and waiting for his moment. And then very quickly, he caught me by surprise and told me why he was there. I'm living in an empty apartment with a cot and a shitty radio. I moved away from my wife 3 months ago. I haven't bought anything for the apartment. I don't know if I'm going back home. Why did you move out? Isaac hesitated and then spoke. He had been sexually abused as a boy and had kept it secret from everyone, including his wife, ever since. He had recently broken his silence, telling his wife, Sarah, what had happened. Her response had made him feel so hurt and angry that he left their home to find some space to regain his equilibrium. He regretted having told her, but now, having opened the subject, he needed to talk to someone. I didn't know how to reply. Sarah had hurt him, and I didn't want to add to his obvious pain. I decided not to ask about the abuse. I asked instead what Sarah had said. Isaac explained that she felt betrayed. Learning that your partner has kept a life-defining experience from you through 25 years of marriage would shock anyone. But at that point, Isaac wasn't up to thinking about Sarah's perspective. Her response, that explains a lot, made him feel small and then angry. But the part Isaac could not forgive was that Sarah had told her girlfriend about it. I imagined she needed some support, but Isaac saw only a circle of expanding humiliation, gossip, and sideways looks that would say that explains a lot. So from the very first time we met, I saw Isaac's strength, and then I was invited into his most painful secret. He let me know that what made him feel safe was to be alone, by himself, with only a cot and a radio. But he also let me know that he could not survive without talking to someone. I was struck by the fact that he could be both a detached calculator of risks and a man so bound by shame. You could string a tightrope between those poles, so dramatic was the tension between them. In a sense, our conversations are about walking that tightrope, sometimes with grace, sometimes just clinging, trying not to fall. So I want to go from that story of internalized and anticipatory stigma to a little manifesto about what we need to do. So the point for healthcare professionals, I think, is that we need to ask. We, by and large, in medicine, function in the dark in a kind of don't ask, don't tell environment in which 1 in 3 of our patients have been exposed to significant childhood trauma that affects our interactions with them and leads them to have difficulties with their healthcare that are inexplicable if you don't know their story and we don't ask them what their story is. And we've done some research about that and found that outside of mental health care, and especially in medical specialties, essentially doctors don't ask. And they have their reasons for that, and those are barriers that we're trying to overcome. So we have, John and I have put together a short video to help doctors get more comfortable with asking about childhood diversity that's available on YouTube, because we think it's actually discomfort with the conversation and not knowing what to do next if you broach the topic that is probably the major barrier. In healthcare organizations, I think it's more and more widely recognized that we need to move towards trauma-informed care, and perhaps less recognized just how hard that is. It's a very complicated process to move the culture of an organization. And this is a map which I'm showing to demonstrate its complexity, not because I expect anybody's going to be able to see those little words, from an organization called Trauma Informed Oregon, which are kind of ahead of the curve on this. Showing how there's a sequence of movement from what's called a trauma-aware organization, which would certainly be where my hospital is right now, where there's a handful of people that understand that this is something that we need to move towards. We're starting to develop champions, through to getting more people involved with that, starting to make it a kind of institutional priority or value. And involving patients, involving families, involving staff in developing what those changes are going to be, until there's actually policy and practice and behavioral change that allows people to be more trauma informed. And that's a process that I don't know how many years that takes, but it's definitely measured in years. And then the last point, trying to be as punctual as Dr. Logie was, which is challenging for me, is that what we need to do to change societally, which is essentially we need to change cultural values, not too differently from how we had to change in response to the dangers that smoking causes when all the evidence was in the 60s. That's about where we are right now with respect to the evidence about the harms of adversity, which involves a number of policy goals that are well known. There's like stacks of government consensus statements and roadmaps. There's no mysteries about what needs to change. The trouble is that it's difficult. And I've listed there some of the strategies that move us towards that. Again, just to show what a long list it is, and even if you just scan over the list, what you'll notice is that those are big changes. They're very broad, they're very expensive. And so in the book, we call that the platform of the most unelectable political party ever, right? And so what we want to balance that against is an appreciation of just how expensive financially childhood adversity is once you take into account all the health outcomes. There was a study in the States that just looked at CAS demonstrated, so verified in childhood abuse, and what the cost of that was for the system. And that is a drop in the bucket underestimate of how much adversity is experienced by kids. And the estimate of the cost of that in the US was $2 trillion a year. So there are financial benefits for making the investments in doing what we should do, even if there weren't financial incentives for it. But it's a tough argument to win, I think. And I will finish there just by noting that we couldn't possibly tell this story without Isaac not only consenting to it, but urging its publications. And nonetheless, I've done my best to disguise who he is. So I'll finish there with, we call this our haiku. It's not technically a haiku, but to make the point that to treat, one needs to be trusted, to trust, one needs to be safe, and to be safe, one needs to be heard. I will finish there.